Just going to introduce the webinar. So this is one of our first webinars that we've switched as a network to doing online. So today we've got 3 experts from Salford Royal Hospital talking around stroke-associated pneumonia, diagnostic, prevention and treatment.
So I'm going to kick off by talking about how we diagnose stroke pneumonia. And just by way of brief introduction, most people will probably know me, but I'm Craig Smith, Professor of Stroke Medicine at University of Manchester and Manchester Centre for Clinical Neurosciences at Salford. So firstly, I'd like to just set the scene about stroke-associated pneumonia. So stroke-associated pneumonia is a major issue, and just to emphasise that, it is common and it occurs in around 8 to 10% of hospitalised stroke patients, but it may occur with a frequency of around 30% or even higher in those that are at greatest risk. A key thing to consider is that stroke-associated pneumonia, which we'll call SAP, occurs very early during the course of the hyperacute and acute admission, and in fact it's most frequently seen within the first 2 to 3 days of admission. One of the key issues about SAP is that it is a major problem because it has adverse impact on outcomes. So SAP is associated with an increased mortality up to 6-fold. It's associated with an increase in length of stay. It's associated with increased institutionalization and poor outcomes in those that go home. And it's also associated with recurrent stroke as an inpatient. One of the other major issues is that SAP is expensive. It almost is associated with significant increased healthcare costs. So we know that it's a problem, and we know that there's an urgent need for preventive strategies. And there's also an urgent need for improved diagnosis and antibiotic stewardship. So Amit will talk a little bit more about treatment, and myself and Jenny will also talk a bit later on about preventive strategies. So next slide, please. So this is a scenario that we're probably all familiar with, whatever discipline you work in, whether you're medical or one of the MDT. So here's an example, a 78-year-old man with a recent left middle cerebral artery territory infarct, fairly high stroke severity with NIH of 16 and nil by mouth after swallow screen. So on day 2, this man develops a temperature of 37.6 and is reported to be chesty, in inverted commas, seems to be making a lot of sort of lower airway noises. And on examination, his GCS is 12, which is probably concordant with the stroke syndrome. There isn't really very much to listen to when the chest is auscultated. There's just a lot of transmitted sounds, and the respiratory rate is elevated, but it's only 18 per minute. And when the blood tests were checked, the C-reactive protein, which is a measure of inflammation in the blood, has more than doubled, but it still remains at a fairly low level of concentration. And likewise, the total white blood count has increased marginally as well. So the question here in this sort of patient is this actually SAP? Does this warrant antibiotics being started? And more realistically, does this warrant or justify not only antibiotics starting, but antibiotics being continued for at least 7 days? Next slide, please. So the question arises, why is diagnosing SAP a problem? And this is really the first fundamental question. So surely it's not that difficult, but actually there's a number of issues. So the first thing to consider is that stroke itself induces both neurophysiological and inflammatory pathways, which create both an acute systemic inflammatory response with parameters like fever and elevated CRP and white blood count. And it also can disrupt the brain respiratory axis, causing hyperventilation on the affected side. It obviously impairs cough. And as a result of this, patients can become tachypneic and they can become hypoxic if they aspirate as well. So all of those features can be very challenging if they can occur just with the stroke itself, which means that if there's infection on top of that, it can be very difficult to determine whether infection's there. So the other issue is that fever itself is certainly an unreliable marker in older people where it isn't always present. And if it is, it may be masked when we treat patients with drugs like aspirin or paracetamol, which are commonly used. And finally, the value of chest x-ray, as we'll touch on a little bit later on, is very uncertain. And the type of pneumonia that we're talking about here is pneumonia evolving in front of our eyes. So this isn't somebody that's been at home for 3 or 4 days, getting more breathless and developing a cough and sputum, and then coming in and a chest x-ray is done several days into the illness. So often we're doing the chest x-ray as the symptoms or the manifestations of potential SAP are actually occurring. Next slide, please. So I'd like to just introduce some concepts around SAP and acute respiratory illness in stroke. So I increasingly consider SAP as part of a spectrum of acute lower respiratory tract syndrome, of which infection forms a part. An infection within the lungs or pneumonia is distinct from other pathologies or other processes that can be going on in the lungs, for example, viral infection, aspiration pneumonitis or mucus plugging with collapse consolidation. And it's also distinct from other discrete pathologies such as pulmonary embolism or pulmonary edema, which is seen in heart failure. But of course, all of these things may coexist together, particularly in older patients with comorbidities, which means that the whole diagnostic spectrum is much more challenging. Increasingly, we might consider whether it's not so important whether we think pneumonia is present per se. For example, are there infiltrates on the chest x-ray, or do people meet particular criteria? But it may be that we should be considering patients as whether they have an antibiotic requiring syndrome or whether they don't. And I think this is an increasing concept which may dispel some of the issues around having definite changes of infiltrate on a chest x-ray and focusing perhaps a bit more in the future on trying to get biomarkers that will detect definite infection within the lungs. Nonetheless, all of these things have implications because we want to get the right treatment at the right time for the patient. Next slide, please. So what exactly is SAP? And this is another schematic which isn't really supposed to look like a fish, but I realized that it did after I drew it. And SAP really incorporates an infective syndrome that occurs within the lungs within the first 7 days of stroke. And there is important overlap both with community-acquired pneumonia and hospital-acquired pneumonia. But the important thing for all of us is that SAP in itself is a discrete entity which merits particular consideration separately from community-acquired pneumonia and hospital-acquired pneumonia. So what we do know is that community-acquired pneumonia or pneumonia occurring before the stroke onset when people are out in the community is fairly common. And in fact, around 20% of people presenting with a stroke will have had a history suggestive of a chest infection or pneumonia. And a recent study where they scanned people's chests on admission along with their brain and with CT angiography showed that around 15% of acute stroke admissions had consolidation, i.e. changes of pneumonia, at least radiologically, on CT of the chest, even when they were admitted, whether they were symptomatic with pneumonia or not. So we know for sure that pneumonia and infection within the lungs can occur before the stroke. So that means that some stroke-associated pneumonia, which is manifesting at, say, day 2 or day 3 after the stroke, could actually just be community-acquired pneumonia. Having said that, once the patient's in hospital or once the stroke has happened, then clearly they'll be subject to the risk of hospital-acquired organisms, which includes Staph Aureus as well as a whole host of other organisms, and they're also at risk of aspiration of organisms from the gastrointestinal tract. And this for me means that a lot of stroke-associated pneumonia is probably what we would call polymicrobial, which means it consists of a whole host of different organisms, both potentially from the community and from the hospital environment and from the GI tract. Next slide, please. So I apologise to Amit if he's going to cover this, but I just wanted to touch on the fact that, to emphasise the point that SAP can be caused by a whole host of organisms. And this is a systematic review that Amit led on, which we published quite recently. And this essentially shows that some of the organisms that we would associate with SAP are things that we would see both in community and hospital-acquired pneumonia, and also indeed ventilator-associated pneumonia, which is really a variant of hospital-acquired pneumonia. So this has quite a lot of implications around how patients may present and the type of treatments that we might need. Next slide, please. So this is another systematic review that we undertook a few years ago when we were starting to get interested in how pneumonia might be diagnosed in the setting of stroke. And this was another systematic review that Amit led on a few years ago. And in this study, what we did was we looked at a whole load of studies that have been published over many years, which reported on a frequency or occurrence of pneumonia after stroke. And what we then did was we looked at how they had gone about diagnosing pneumonia in those studies, and we categorized the diagnosis in 4 ways. So the first category was no record at all of how the pneumonia was diagnosed. The second was an unspecified clinician diagnosis, and this was essentially where clinicians just said, we diagnosed pneumonia, or we recorded who got antibiotics. And this is based largely probably on what we would call experiential diagnosis, where clinicians see patients and they make an assessment on a particular day at a particular time and say, I think this person has pneumonia. So they don't use specific criteria that have to be met, but they just use their own experience or judgment. The third category was objective criteria. So this is where criteria were used that had to be met in a certain way, but these were just ad hoc and they appear to have been made up for the particular study in question, and they hadn't been published before. And the final category was the use of published respiratory or societal criteria. So these are things, for example, the CDC criteria or the MAN criteria, which have been published previously and may or may not have been validated. So what we found was that there was a large variation in the way that pneumonia was being diagnosed, and nearly 10% of people didn't even record or report how they actually diagnosed it, and only a third used published standardized criteria. So the bottom left slide is a bar chart, and you can see that it's frequency on the y-axis, and on the x-axis there's a range of different parameters that could be used to diagnose pneumonia. And what we can see when Amit looked at all of the different factors that we used in the objective ad hoc criteria, it would appear that an abnormal chest x-ray, cough, sputum and pyrexia were the features that seemed to be most heavily relied upon. But when we looked at the published respiratory or societal criteria, you can see that for 3 that are listed there as an example, the AT-SIDS, the MAN criteria and the CDC criteria, you can see that for a whole list of different parameters or variables to diagnose pneumonia, there's only 2 that were required for all 3, and that's cough or purulent secretions and also pyrexia. And chest x-ray was only mandatory in 2 of those societal criteria. So what this study really concluded was that there was huge variation in the way that people were diagnosing pneumonia. Next slide, please. So we then took this a little bit further and asked the question, how much variation actually is there in the diagnosis or prevalence of pneumonia in stroke unit care? And to do this, we did a study using data from SNAP, which you'll all be familiar with, and we used individual patient data, which means going to SNAP and getting individual patient record data and pooling it together. And this particular analysis here, which we've actually updated with the current PhD student, was in 230,000 patients in 186 units. And what we did here was we compared the observed prevalence of SAP, and the observed prevalence is in the orange coloured figure out of the two. An observed prevalence of SAP is that which is recorded in SNAP, and the variable there is antibiotics that have been started after admission to the stroke unit within 7 days for pneumonia. So that is observed SAP prevalence. And you can see from the orange figure that there's quite a large range of variations. So some units are right down near sort of 0, 2 or 3 prevalence, and others are up near 25%. So observed prevalence is enormously variable between units across the UK. So then what we also did was using factors that we know are associated with the risk of stroke, for example, age, NIH stroke score, atrial fibrillation, and other factors. We created a regression model to predict how much pneumonia you would expect to see based on those clinical factors in each of the different units. And the blue figure that's above the orange one is for this predicted pneumonia prevalence. And you can see that the line is much flatter. And that shows that predicted SAP prevalence based on clinical characteristics of patients is far less variable, which is really quite striking compared to the observed SAP prevalence. So what this means is that clinical characteristics don't seem to actually explain a great deal of variation in the wide range of SAP prevalence that we see between units. And what this probably means is that there are other factors that are going on in the stroke unit that are helping to explain why there's so much variation in SAP prevalence. And part of this could be the way clinicians are diagnosing SAP. And the reason that this is important is because if there is such a huge variation in SAP prevalence, which could be driven perhaps by variations in how clinicians are diagnosing SAP, then this could have massive implications both for antibiotic usage and for clinical outcomes. Next slide, please. So this brings me on to a little bit more about why it all matters. So why is anyone bothered about this? If we think someone's got pneumonia, why don't we just give everybody antibiotics and not worry? Well, the first thing is we need to make sure that it isn't something other than pneumonia that needs to be treated, as I alluded to earlier. But also, as we all know, antibiotics are not a resource that's non-exhaustible. And unfortunately, at the moment, we need to emphasise the fact that antibiotic usage is increasing year on year. Antibiotics are becoming a real issue in terms of the pharmaceutical industry. People aren't terribly interested in finding new antibiotics. And a major issue is that antimicrobial resistance is increasing worldwide. And as we all know, there are a number of organisms now that are emerging, particularly in the hospital environment, but also in the community, which are becoming almost impossible to actually treat effectively with antibiotics. So at an individual level, it's also important patients with stroke may come to harm from having antibiotics if it's unnecessary, for example, by developing Clostridium. And of course, overtreatment with antibiotics is contributing very significantly to antibiotic usage in the UK. So there are over 5,000 episodes of SAP in the UK annually, which means there are at least 7,000 to 10,000 antibiotic prescriptions that are happening each year. Next slide, please. So with all of that in mind, we started to move towards looking at, are there any standardized diagnostic criteria? And the answer to that is that there are no validated criteria in the literature. So what we did was we got together a group of people that were interested. We called ourselves experts based on the fact that we were doing research into SAP and pneumonia in stroke. And we came up with consensus criteria using a Delphi type approach and then published these. And these criteria are, I need to stress again, consensus opinions. So they are only a proposal. They're based on the CDC criteria, and they are rather arbitrary in terms of all of the thresholds. So example, a fever of 38, nobody really knows where that came from. Leukocytosis of greater than 12,000, nobody really knows where that came from. tachypnea with a respiratory rate of 25, which is actually really quite high. Nobody really knows where that came from. So the CDC criteria have mandatory appearances of infiltrates on the chest X-ray, and we considered this and thought, do we really need to actually mandate chest X-ray infiltrates? So what we said was we would have two syndromes. We would have definite SAP, where these criteria were met, and there were also changes on chest X-ray, preferably serial changes on chest X-ray, and then we had a probable SAP criteria where we would expect clinicians would treat, but would review the diagnosis perhaps more rigorously where there wasn't initially chest X-ray changes. Next slide, please. So are algorithm-based approaches any good? Well, what we do know is that there's a tendency for clinicians to overdiagnose stroke associated pneumonia when they just experience or judgment when that's algorithm approaches. And what I mean by algorithm approaches are what we've discussed earlier, where we have specific criteria that are standardized that need to be met before a diagnosis is made and treatment is started. So in this study, which is from Stroke Inf, which was a large prophylactic antibiotic study, there was recording of both clinician diagnosis of SAP, there was an adjudicated panel diagnosis of SAP, and there was an algorithm diagnosis of SAP. So what we did in this study was we took the adjudicated expert panel diagnosis as the reference standard, and then we asked the question, how good was clinician diagnosis or algorithm diagnosis compared to the expert panel diagnosis? So it's worth bearing in mind that this population in Stroke Inf had infiltrates on chest X-ray in only just about a third, and only 3/4 of them had fever. So what we can see from the analysis, and I'll just briefly mention something on sensitivity and specificity. Sensitivity is the number of people that really do have SAP that were picked up either by clinician diagnosis or the algorithm. Specificity is the number of people that really didn't have SAP that were truly correctly classified as not having SAP. So that you can see that the sensitivity of the algorithm diagnosis was not brilliant at only 72%, but it was certainly better than physician diagnosis on its own. So a sensitivity of 65% means that 65 out of 100 cases of SAP would be correctly identified, but unfortunately 35 out of those 100 would be incorrectly labelled as not having SAP. Now this is not good if you want to rule SAP out using an algorithm or physician diagnosis. You can see that the specificity, which is the ability to correctly label people as not having SAP, is good. But this then did make us ask the question, could we improve algorithm diagnosis by adding a basic biomarker which we use in clinical practice, for example, CRP? Next slide, please. So what we then did was added CRP to the algorithm. We completely forgot all about the clinician diagnosis and just focused on the algorithm. And we said, if we had a pneumonia diagnosis algorithm and added CRP, would that make any difference? And adding CRP to the algorithm alone made no real difference to the diagnostic accuracy. However, if we added the CRP to people that had no fever and created an algorithm where there was fever or an elevated CRP above 30, then this algorithm substantially increased both the sensitivity and all of the other diagnostic parameters. So the use of CRP in this algorithm, if there was no fever, improved the sensitivity to 94%. So this means that out of 100 people with SAP, 94 of them were picked up and only 6 were missed. So at this stage, we can't really recommend that this is the way you should diagnose SAP, but certainly this is an approach that needs further evaluation. Next slide, please. So what about biomarker-guided diagnosis? And this was a study done by some of our colleagues in Germany and Spain, where they used a blood test called procalcitonin, a stress marker that's released from various tissues in the body, when the body is stressed, for example, with an infection or with trauma. And unfortunately, like CRP and other stress markers, procalcitonin is released both as a result of stroke, but also as a result of infection. But many people argue that procalcitonin is a marker of infection. So in this study, which was a randomized trial, stroke units were randomized to either do whatever they do normally when they start antibiotics and diagnose pneumonia, or to be advised to rely on the concentrations of daily procalcitonin. So what that means was that the stroke units that got the procalcitonin arm of the trial were advised not to start antibiotics and make a diagnosis of pneumonia unless a particular threshold of blood procalcitonin was met. So the first notable result was that actually the advice to stick to the procalcitonin level based diagnosis was only actually followed in 2/3, which is a worry because that tends to mean to me that 1/3 of clinicians think they know better than the biomarker. But even when it was used, unfortunately, procalcitonin did not lead to a better outcome for these patients. So there was no real difference. And in fact, the only difference that they found was that more antibiotics were actually used in the group that were randomized to procalcitonin. So currently this is slightly disappointing, but it means that there certainly isn't a role for procalcitonin in diagnosing pneumonia and initiating antibiotics. So next slide, please. So what about other types of imaging for the chest? So I'm going to touch briefly now on chest X-ray and pulmonary CT, and these are some figures from a study that we've just finished and Amit has submitted for publication. So in this study, we looked at patients with a clinical suspicion of staph, where clinicians had started antibiotics, and we compared the chest X-ray that was done routinely in clinical practice with the CT scan of the chest that was done within 48 hours. So here's two examples. So the first is a 51-year-old patient with severe stroke. It's fairly tachypneic, got a fairly convincing fever, has been hypoxic, and has got a reasonable CRP, but not terribly high. So the chest X-ray is not terribly convincing of any infectious change, but the interesting thing is even a CT scan that was done 13 hours after that was also fairly normal. So there's no evidence of pneumonia in this patient. And in the second one, less severe stroke, arguably less convincing signs of a clinical pneumonia. Again, the chest X-ray is fairly normal, and there's no evidence of any pneumonia on the chest CT either. This one was done slightly later. And the arrow there just shows a little bit of mucus in part of the bronchial tree. So from these two patients and from others, it made us just think, well, maybe some of these patients that appear to have pneumonia haven't actually got it when you do a CT scan. And what does that actually mean? So next slide, please. So we then looked a little bit more formally at how useful a chest X-ray is in diagnosing SAP. And remember, I said that the chest X-ray is often done here in front of our eyes as pneumonia is evolving. So it's not done 2 or 3 or 4 days after symptoms started. So here we compared the chest X-ray with the pulmonary CT, where we said the pulmonary CT was the reference standard. So if there was pneumonia on the pulmonary CT, that person had pneumonia. And these were all people with clinically suspected pneumonia. And what we found was that the sensitivity of chest X-ray was not even 60%. And again, you'll recall this means that it misses around 40 people out of 100 that have actually got SAP compared to a pulmonary CT scan. The specificity was also poor. And again, the sensitivity being that low means that it incorrectly classifies 26 people out of 100 as having pneumonia, which would mean that they would potentially have a course of antibiotics when they didn't need it. So if you can remember the previous slide about algorithms, this means that the sensitivity and specificity are actually worse than using the algorithm compared against an adjudicated panel using clinicians. So what does this mean? What this means that chest X-ray has very limited usefulness. It may show you an alternative diagnosis, of course, such as pulmonary edema or a pneumothorax or a large pleural effusion or whatever, but it has very limited accuracy. for people with suspected SAP. Next slide, please. So in summary, SAP remains a major unmet need. It's a real problem in stroke unit care in terms of adverse outcomes, length of stay and healthcare costs. Diagnosing SAP definitively and using methods to try and appropriately get antibiotics initiated is very challenging. We don't know what the role of blood biomarkers, either ones used routinely in clinical practice or more evolving ones, we don't know what the role of those are. Evaluation of algorithm-based diagnostic approaches is required, but seems to certainly be superior and a better approach than clinicians just making it up as they go along. And it might be that pulmonary CT could be a useful way of approaching all of this in the future in terms of validating algorithms or biomarkers. Next slide, please. So in the future, I would see that we need more standardized approaches to be more widely evaluated and validated. We need emerging immune, stress, inflammatory and omic approaches, including exhaled breath. Panels of biomarkers could be the way forward, with serial daily sampling within a sort of high risk area of a HAZU where patients were felt to be at risk of pneumonia. There could be a role for bedside thoracic ultrasound, which I haven't touched on today, but that might be something that could be valuable. And what we need is to work towards robust decision tools which will have an impact on antibiotic stewardship and won't disadvantage patients in terms of clinical outcomes. So final slide, please.
I'm Amit Kishore. I'm the stroke physicians at Salford. Thanks, Craig, for the fantastic talk on diagnosis. I'll be talking today on the treatment of stroke-associated pneumonia. I'm hoping to bring some science to this because obviously a lot of you will be wondering what is that in treatment, because antibiotics, of course, are the mainstay. I've got no disclosures, but of course I'm not a respiratory physician, microbiologist or intensivist. And when I started off with Craig a few years ago on this particular area of stroke medicine, I almost felt like an imposter, as this didn't feel like it was my field to deal with. But pneumonia, as you have already heard, is one of the most important and frequent and most associated with significant amount of morbidity and mortality. And it's only right that stroke physicians are closely involved in the diagnosis and management of stroke. I'm hoping to get information from the other specialties into this particular area, and hopefully we'll be able to find some evidence for treating stroke-associated pneumonia. So Craig talked about the consensus meeting which happened 5 years ago on the diagnosis, and we held a similar one 3 years ago, looking at how we would address the topic of treating stroke-associated pneumonia. And again, this was a consensus meeting using a modified Delphi approach. It involved a group of infectious disease specialists, microbiologists, stroke physicians, statisticians. And we thought that we should be addressing two areas mainly. One is what are the bugs or the bacteria which cause pneumonia, complicating stroke? And the other aspect was what antibiotic treatment and what evidence was there for providing antibiotic treatment. I briefly cover on supportive treatment, but I think Jenny would be talking a lot more on that later on as well. So the first part of the consensus was looking at what are the microbiological etiologies for pneumonia complicating stroke or stroke-associated pneumonia. So when we started off with this, I thought that it's best to look at how bacteria are classified and just a bit of understanding as to how this is. So there's two different types of classification. One is looking at the phenotypic structure or how the bacteria look. Another one is genotypic, analyzing the RNA and the DNA structures. In terms of the phenotypic classification, so the Gram staining was introduced about 150 years ago and even now remains the gold standard for the phenotypic approach to bacterial classification systems. So using a particular dye, crystalline violet dye, you basically stain the bacterial cell wall and classify it as Gram positive based on the presence or absence of the peptidoglycan structure, the protein structure which surrounds the bacteria. bacterial wall. So if gram-positive bacteria have this structure, which is pretty prominent, and they stain easily, whereas the gram-negative ones, they don't stain with this particular dye, they stain with some other dye. I'll talk about that in a bit. And then you've got the morphology, the size and shape of the bacteria, the circular spherical ones, which are the cocci, and then you've got the bacilli, and you've got the spiral bacteria. You're also looking at the growth requirements of the bacteria, which is either aerobic or anaerobic, based on the requirements for oxygen, or they could be facultative anaerobes, where they can grow with or without the presence of oxygen. So most commonly, as you heard, it's the aerobic gram-positive cocci. Commonly, we refer to them as Strep pneumonia and Staph Aureus, which are the most common ones which we are aware of in the field of pneumonia. You've also got the anaerobic gram-negative bacilli, which are the coliforms, namely the Klebsiella and the E. coli, as well as Pseudomonas. If the bacteria don't die, they're called atypical bacteria. Just as an example, the gram-positive bacteria stain violet blue, and the gram-negative bacteria, the bacilli, as such, will stain pink. As a first step, we look to identify what bacteria are present in patients who are suffering pneumonia after a stroke. And we performed a systematic review and meta-analysis of looking at all the studies which had sent off cultures for bacteria. Unfortunately, despite several thousands of studies on stroke and several hundreds of studies on infection, we could only identify 15 studies which identified bacteria following pneumonia. And this is not surprising because, as you can imagine, it's quite hard to take sputum cultures of non-ventilated stroke patients, and at best we would probably get blood cultures out of people who are having fever. And even in this group of patients, we had about 40% of patients who had sputum cultures sent. But the vast majority of them had a mixture of sputum cultures and blood cultures, or pleural fluid aspirates, or tracheobronchial aspirates. What I've identified is the top 8 organisms which we've identified in the systematic review meta-analysis. So it's a mixture of mainly gram-positive cocci, which is the Staph Aureus and Strep pneumonia, and the aerobic gram-negative bacilli, which is the Klebsiella and the E. coli, as well as the Haemophilus enterobacter and Acinetobacter. So these are the common organisms which the top 8 organisms which we identified in our review. In total, there were about 15 studies involving about 8,000 patients. There was significant heterogeneity in this meta-analysis, mainly related to when the samples were sent off in relation to the diagnosis of pneumonia, how the pneumonia was diagnosed. As Craig had pointed out, different criteria were used to diagnose pneumonia. Some of them used the modified, some of them used the CDC criteria, some of them used their own adjudicated criteria, some of them just use a clinician diagnosis. So again, there's a difference in how pneumonia was diagnosed. Further, it is unclear when these samples were sent in relation to the diagnosis of pneumonia. And about half the studies were conducted in Southeast Asian countries. You're probably all aware that the bugs which you find, are slightly different to the ones here. So again, there's a bit of heterogeneity in this. The most common identified bacteria among all causes of pneumonia was Staph Aureus in 14 of the 15 studies. And equally, about 50% of the more than 50% of studies had enterococci as well as Strep pneumonia. We then looked at and compared these top 8 organisms against those which were found in hospitalized community-acquired pneumonia, as well as in HAP and VAP. So when you look at what the bugs are there in the community-acquired pneumonia, Strep pneumonia accounts to almost more than 50%, sometimes up to 80% of all cases of community-acquired pneumonia. Similarly, if you look at HAP and VAP, you'd find aerobic gram-negative bacilli. And if you look down the tables, vastly it is Pseudomonas, or enterococci, which are fairly common. Staph aureus, as well in hospital-acquired pneumonia, is fairly common. If you look down the right side of the table, in terms of what we see in stroke-associated pneumonia, you can see there's a good spread of bacteria. Now, there's a good mixture of bacteria, but there's a preponderance towards bugs which are aerobic gram-negative bacilli. So they are fairly similar to the ones you find in hospital-acquired pneumonia. So almost 36% of all the pneumonia seen in this analysis was caused by aerobic gram-negative bacilli, and about 18% was because of gram-positive cocci. So there's a good mixture, and it is only right to assume that if you have pneumonia quite early on after a stroke, that the bugs might be more like the ones which you see in the hospitalized community-acquired pneumonia, and perhaps later on it could be because of the aerobic gram-negative bacilli. However, we could not prove that in the systematic review. So again, this is a table comparing the bugs commonly seen in SAP, HAP, and hospitalized community-acquired pneumonia. In the hospitalized community-acquired pneumonia, in other studies which are not involving stroke, strep pneumonia is fairly common, as well as H. influenzae, moraxella. Obviously, we cannot forget atypical bacteria and viruses. In the HAP organisms, you can see a lot of aerobic gram-negative bacilli, and SAP, obviously, I've talked about it. There's a good mixture of both, really. So coming to the antibiotic treatment of SAP and why it is important. Of course, antibiotic is a mainstay of treatment, and as you're all probably aware, when we start antibiotic treatment, it's usually based on the local CAP or HAP guidelines. And as I've already described, the microbiological etiologies, the bugs which we find in our group of patients, they vary, and they've got both HAP and CAP organisms. You also have to remember that there's a transient peripheral immunosuppression with stroke, and there's an impact of this on infection. There's an impact on this immunosuppression on antibiotic use. You have to remember that some of the antibiotics also have an anti-inflammatory and immunomodulatory effects. And there's also the importance of antibiotic stewardship, now, which refers to appropriate use of antibiotics. Perhaps along with VTE prophylaxis, antibiotics are the most scrutinized part of my ward round anyway. So what was the remit of our second consensus meeting on antibiotic treatment? We thought it was only fair that we should restrict the guidance as such. And again, this is not a guideline. This is just a consensus opinion of specialists who deal with this, who have an interest in this area. And we thought that we should restrict whatever consensus we have or the guidance to only within 7 days, as the majority of the pneumonia, even in our study, had occurred within the first 7 days. And we thought that it's best that we consider that pneumonia occurring beyond 7 days should be referred to guidelines for HAP, or hospital-acquired pneumonia. Similarly, if the patient is ventilated beyond 7 days, clinicians should use guidelines for WAP. So just to give an example, so you've got an 82-year-old man who's on day 2 following a stroke. He's got a total left anterior circulation syndrome with a productive cough. He's got a temperature of 38.1, mildly confused, tachypneic 24 per minute, a SATs of 92% on room air, blood pressure seems okay, urea of 6.9, EGFR of 77, he's got crackles on the left base. He's failed his swallow assessment. He's got a slightly, say, probably raised CRP at 36. Of course, contextually, the COVID swabs have been negative. And he's got a horrendous looking X-ray there, as you can see, slightly big heart, bit of fluid in the lungs. He's got bibasal changes. Of course, while you're there, make sure you don't forget to look at the position of the chest X-ray, which looks dodgy here. So I think this X-ray is fairly convincing. Most people would agree that this would look like pneumonia. So as before we start antibiotics, of course, you need to understand how you would go through choosing the antibiotics. First of all, diagnosis is important. Need to look at what antibiotic you use, and that would often be dependent on the severity of the pneumonia. what route, and how long for, and when would you step down? So in terms of diagnosis, I've highlighted in red what, based on what Craig had already spoken about in terms of the consensus, in terms of the modified CDC criteria for diagnosis. You would look at, based on our PICES guidance, this particular patient would fulfill most of the criteria here, having being older, with a fever, with a cough with a purulent sputum, he's got crackles, he's got slightly low SAT, so he meets in the clinical criteria for probable pneumonia, as well as the X-ray criteria for definite pneumonia. So there's obviously seems to be beyond doubt that this patient has an infection in the lungs. So the next step is to look at what antibiotics we would be using here. And the first thing we did was to look at and see if there's any definitive studies out there, randomized studies or any studies which looked at treatment, evaluating using antibiotics, evaluating the outcomes with stroke-associated pneumonia, and we couldn't find any out there. Craig then looked at the virtual international stroke trials archive. I'm not sure if you're aware of this, but this has got the largest database of individualized stroke patients from randomized controlled trials, so you can get individual patient data from this database. And he looked at about 2,900 patients who had infection post-stroke and who had received antibiotics within 2 weeks, and approximately over a third of them had pneumonia. And Craig found out that basically the only antibiotic which seemed to have an association with a favorable outcome in terms of MRS distribution was macrolides, which were prescribed in about 8% of all the patients. It was unclear why that this was the only antibiotic, but macrolides have no gram-negative cover, but they're effective against gram-positive and atypical organisms. Interestingly, macrolides also have a significant immunomodulatory effects and anti-inflammatory effects, and they're used in a number of dermatological and rheumatological conditions because of the effect on interleukins and TNF-alpha. So I think that's potentially something to have to bear in mind, and perhaps there's to consider more research on, really. So I looked at the spectrum of antibiotic cover for the top 8 organisms in pneumonia. This is quite a busy slide, but to summarize, the beta-lactams seem to be the mainstay for most hospitalized community-acquired pneumonia as a first choice of treatment. And you can see that the beta-lactam antibiotics have a largely gram-positive cover, with strep pneumonia and Staph aureus being well covered. And as you go down the beta-lactam group, extended spectrum antibiotics like comoxiclav and the PIP test combination have even gram-negative and anaerobic cover. Similarly, the cephalosporins as well, as you go down the generations, they seem to have a more broader spectrum antibiotic cover. The macrolides predominantly have atypical cover as well as gram-positive cover. The tetracyclines are probably the quite broad, and the advantage is that it can be given orally as well, and it has both gram-positive and gram-negative cover. Levofloxacin and the quinolone group, well liked by the American societies. They seem to have very good strep pneumonia cover, not Staph aureus, and as well as the gram-negative cover. Metronidazole is fairly useful only against the anaerobes. It's a synthetic compound. A lot of the other antibiotics are derived from bacteria. So the next step, once you decide on what antibiotics you want, is to check this. Prior to deciding antibiotics, you obviously need the severity. Now, if a patient comes in with stroke and has a pneumonia at day 2, automatically at least at Salford, we are expected to look at the severity of the pneumonia. And we often use the CURB 65 score here. And in this case, based on what parameters were given, the score was 2, associated with 9% mortality. Using the CURB 65 score, the local SRFT policy uses a combination of benzyl penicillin which is a beta-lactamase. It has a good cover for gram-positive bacteria, and doxycycline, as I mentioned before. Doxycycline is great for, it's got a very broad spectrum for both gram-positive and gram-negative. So you'd expect to continue antibiotics for about 24 hours intravenously and look at clinical response and consider step down to oral amoxicillin and doxycycline and continue it for 7 days. And if you have more severe spectrum, you can see that the you're using more broader spectrum antibiotics with co-amoxiclav straight away. So once you look at the local policy, I wanted to also look at what other societies are providing guidance on hospitalized community-acquired pneumonia. Perhaps the European Society is the only one which looks at the aspiration pneumonia perspective with concern for stroke patients particularly. And interestingly, a lot of these, both European and American societies, they favor quinolones rather than the doxycycline group of medicines, along with the beta-lactamase group. So a lot of the directive is on using beta-lactamase with quinolones here among both European and American societies. So what did we recommend based on what evidence we had looking at the local European and American societies? And we felt that based on the available bacteria, based on the systematic review we had done, we felt that early SAP or SAP within the first 72 hours, as we classified it, we thought that empirical antibiotics to cover typical community-acquired pneumonia organisms, mainly gram-positive cocci, in addition to H. influenza and Moraxella, are recommended. So H. influenza and Moraxella are gram-negative bacilli, so a mixture of typical CAP organisms, which includes strep, pneumonia, as well as H. influenza and Moraxella. And this is something which we've based on the available studies on community-acquired pneumonia. So, for example, in our patient, using penicillins, the benzyl penicillin and doxycycline seemed reasonable because it will cover most of these organisms. For late SAP, so beyond 72 hours, empirical antibiotics to cover coliforms, and depending on what the risk of the patient is, I'll talk about it in another slide later on. Pseudomonas curve should also be considered. Now, we didn't think additional antimicrobial coverage was needed for aspiration. And I'll again talk about this later, but there's been more recent studies looking at aspiration pneumonia and the type of bugs, and anaerobes don't seem to figure quite highly in this. So in terms of how soon do we give the antibiotics? Again, we looked at the BTS guidelines and other guidelines here for recommendations, and we felt that we could not change because of the lack of evidence on when we should start it. And we felt that we should be starting antibiotics as soon as possible, and certainly within 4 hours. And if there are signs of sepsis or septic shock, then as soon as possible and within 1 hour. We have used CURB 65 scores in this case, but again, there's currently no validated severity scores for SAP. And existing pneumonia severity scores would require further evaluation in SAP patients. However, if the patient had a cough on day 1 or at the time of presentation, we felt that it would be difficult to exclude community-acquired pneumonia. And we felt that if pneumonia also precedes stroke, they should follow the local and national CAP guidelines. So again, in terms of choice of antibiotics, this is generally a broadly recommended treatment. In terms of early SAP, beta-lactams and macrolides or quinolones seem satisfactory. I think the quinolones was chosen because European and American societies favor this over doxycycline. The late SAP, again, we included common beta-lactamase in combination with beta-lactams, 3rd or 4th generation cephalosporins. Fluoroquinolones or aminoglycosides were chosen for this based on a cover for hospital-acquired pneumonia bugs. We also had anti-regime for at least 7 days, and this should be guided by clinical response. So I briefly talked about aspiration pneumonia, and we previously thought that this was predominantly due to anaerobes, such as the bacteroids of Fusobacterium. More recent studies, as I said, less contribution from anaerobes. with greater prevalence of Staph Aureus, gram-negative bacilli, and aerobic organisms. And again, this is reflected by the societal guidelines recommendations on aspiration pneumonia. However, you have to bear in mind that if they have specific conditions like abscesses, periodontal disease, or empyema, then an additional anaerobic cover will need to be considered. So when do we consider Pseudomonas? If a patient has pre-immune suppression conditions like previous transplant on immunosuppressants, who's got severe burns, patients with pre-existing lung diseases like cystic fibrosis, patients who've been mechanically ventilated, they've already used antibiotic therapy once, so you would need to consider Pseudomonas cover if they're not responding to regular treatment. I thought I should talk briefly. Craig has already covered this this area as well. Talk briefly on the differences between what aspiration pneumonia is and SAP, because in my mind, aspiration usually suggests a macroaspiration, so somebody who's violently sick and is vomited a large amount, so you could actually see that where this would come from. So you'd have major changes on the X-ray, and there's usually associated dysphagia and GI dysmotility. It's quite rapid in onset, and you would see the features of consolidation quite obviously on the chest X-ray. And again, we talked about microbiology here with aerobic gram-negative bacteria and gram-positive bacilli with or without anaerobes. Whereas SAP is more of a microaspiration, I would think, and associated stroke-induced immunosuppression, dysphagia, and GI motility, as with aspiration. It's potentially less rapid, and you're less likely to find chest X-ray findings early on. And there's a mixture of organisms, and it's unclear if viruses are contributing to this as well. So for the same patient, supposing that he had recovered, and on day 10 he again shows signs and symptoms of severe pneumonia, then you'll have to consider that this is recurrent pneumonia following an initial course. You should try and treat this as in line with treatment guidance for HAP with cover for Pseudomonas. And we use severity criteria still here because it's HAP, and you could use SIRS criteria, for example. And again, here the choice of first treatment with tazocin. If you're suspecting more deeper infections, you should consider MRSA as well as ESBL. So there's several clinical conundrums which can happen when you consider treatment. For example, if you have a patient from a care home who spent the last couple of years in a nursing home, how would that antibiotic spectrum change? Would you consider Pseudomonas here? Again, I talked about immunosuppression. You definitely should consider Pseudomonas in this case. If the patient is ventilated on day 3, what sort of antibiotic cover would you provide? The general recommendation based on the consensus was that you would continue to provide antibiotics in line with what we think is seen in the first half of a SAP. However, beyond the week, you would look at hospital-acquired or WAP criteria, antibiotic criteria. Now, how do you monitor progress or resolution? Would you repeat a chest X-ray at 1 week or at 6 weeks? Would you monitor this with CRP? Would you use clinical criteria? So there's a number of questions here which need to be borne in mind, which we didn't address in the consensus. Now, would you provide, this patient already had a nasogastric tubing, but if the patient is having an acute pneumonia syndrome, and would you consider putting an NG in him, and would you consider ongoing feeding in this person? And what is the role of advanced imaging even in treatment? Would you monitor treatment using ultrasound? So there's a lot of both clinical questions as well as research questions which still need to be addressed. So the paper which we submitted has this flow chart, which is really useful, which provides guidance, the antibiotic treatment guidance on SAP. I think it's quite nice, and it basically covers what I've talked in terms of when we should be using what antibiotic to cover the type of organisms. We looked at in terms of decisions on step down and how we would treat patients who are initially dysphagic, which is likely to be predominantly intravenously. So I think it's quite useful to read this paper to see if we can influence local guidelines at least. I'll talk briefly on supportive treatment, and which forms you need to give time for antibiotics to kick in, and providing oxygen, painkillers, and fever relief with paracetamol, making sure that the patient has adequate DVT prophylaxis. whichever form, and adequate nutritional support. There's some controversy about mobilization and head positions, which Jenny will talk about, as well as Craig. You need to look at support with airway clearing secretions to avoid superimposed aspiration. If the patient has pleural fluid collection, then you need to look at drainage, you need to consider intensive care involvement. So all of this is perhaps more supportive, but the mainstay would be antibiotic treatment. So to conclude, I think I started off with something like an imposter syndrome, but hopefully over the past 3 years or so, I've tried to, with Craig, we've tried to basically incorporate a lot of information from other fields of medicine to try and improve the care of stroke patients who have got infections, particularly pneumonia. That's it, really. Thank you.
So now I'd like to talk a little bit about how we might approach trying to prevent stroke-associated pneumonia, and then Jenny's going to do the final talk, which will focus a lot more, I think, on therapy aspects, but I might just cover a couple of those things briefly. So next slide, please. So the way I would consider approaches or strategies to be able to prevent SAP really would be to think of the pathophysiology of the disease as we know it. So this diagram really is just to give you a bit of a brief overview of the way I would consider it. So we've obviously got a picture of somebody with their sort of upper GI and pulmonary system exposed. So if you imagine that they've had a stroke, I would consider 4 potential approaches as to how we might be able to prevent SAP. So the first one on the left is that, as you've already heard, SAP has to have an infectious substrate. There has to be some bugs that come from somewhere. And generally speaking, most of these bugs, or in nearly all cases, certainly aren't living in the lungs to start with. So they've got to come from somewhere else. And the 2 main sources within the individual themselves, as opposed to their environment, are the oral cavity, which obviously includes the mouth as a whole, and also then the upper nasopharynx area. So we have a lot of microorganisms that live both in our nasopharynx and also in our oral cavity. So there is potentially infectious substrate from the lower GI tract. The stomach's fairly sterile because it's a very acid environment, but we do know, as you've heard from Amit, if you aspirate from lower down in the bowel, you can, of course, end up with a certain group of organisms going into the lungs then. So the second approach is around oropharyngeal aspiration, and there's been many of you in the audience know a lot more of the detail and the physiology about how we protect our swallowing in terms of how we protect against aspiration, both in terms of traditional oropharyngeal aspiration, but also pulmonary clearance. So pulmonary clearance comes into the oropharyngeal aspiration bit, but it also comes into the lower part of the bronchial setup in terms of mechanisms such as mucus and mucociliary transport to remove material upwards so that it can be coughed out. So oropharyngeal aspiration, it's often considered separately from the brain respiratory axis, but of course cough and swallowing mechanisms to prevent aspiration clearly work together to prevent aspiration. And the final one, which is a little bit more experimental, is around immune suppression. So after you have a stroke, your immune system becomes impaired very briefly, both in the blood and in the brain. And a side effect of that is that the impairment to the immune system means that you're potentially more susceptible to infection. Next slide, please. So we've already seen this before, but I'm showing it again just to illustrate how important it is. If we think we want to prevent SAP, then we probably need to understand a little bit more about which bugs we're dealing with. Next slide, please. So in no real particular order, I'm going to try and start at the top and move downwards, and then talk a little bit about stroke unit care and some processes. So no real particular order, but I'll start with oral health care. So many of you will know that oral healthcare is important in stroke. It's important both to stroke survivors and also to staff. We have very little evidence to guide us in terms of how to provide oral healthcare, but we do know that there's a link between bugs in the mouth, aspiration and pneumonia, and this is true not just in the stroke setting, but perhaps more important in the stroke setting than other areas where dysphagia is such a common problem. So there have been several trials that have been done looking at oral healthcare interventions. Very few of them, if any, in fact none really, have tested any oral healthcare interventions specifically to see whether they reduce the likelihood or prevent pneumonia. Many of them have looked at indices of plaque in the mouth to see whether that particular approach to mouth care has reduced the amount of plaque in the mouth. So what we do know is that chlorhexidine, which is a broad spectrum antiseptic type of approach, which many of you will be familiar with, you can buy chlorhexidine gel in the chemist and apply it to your gums and teeth. If you use chlorhexidine and if you use a powered toothbrush, then this may well be a good way of preventing pneumonia. And there's certainly evidence from the intensive care unit setting that chlorhexidine rather than toothpaste significantly reduces the likelihood of pneumonia from developing. But interestingly, in that setting, there is no evidence to support how the teeth are actually brushed. There are a lot of unanswered questions, and there is some ongoing work, including within our group, about oral healthcare and preventing pneumonia. Essentially, we really need large-scale, well-designed and feasible randomized trials. Next slide, please. So the next approach is selective decontamination of the upper digestive tract, and this is not the same as oral healthcare. Oral healthcare is about cleaning the mouth and providing holistic care to the mouth on an individual level, whereas selective decontamination of the upper GI tract is about providing antibiotics, with the idea being that they disrupt the normal balance of organisms that live in that particular area of the body. So there was a trial done many years ago which was never followed up at a single site, and this used an oral paste which contained several different types of antimicrobial agents. This was given, I think, 4 times a day for 2 to 3 weeks after stroke. Obviously, some of these patients were dysphagic, and interestingly, it was given even in those days within 24 hours of admission, so quite an impressive study at face value. And there was a reduction in pneumonia, and there were no apparent adverse effects and no real feasibility issues. But curiously, this trial has never been followed up, and it's been nearly 15 years now since it was actually started, at least, and for some reason this has never really picked up. Those of you that remember the original MAPS-2 trial, which unfortunately folded before it started, will remember that this was a component of the 2-stage intervention along with metaclopramide. So is there a future for this? I don't know. Next slide. So a very common and up until recently popular approach was to give antibiotic prophylaxis orally, or at least through injection, or orally or through NG tubes or PEGs. So this approach relies on giving broad spectrum antibiotics to patients as soon as they've had the stroke or shortly after, the idea being, again, to try and prevent pneumonia from happening. And interestingly, there's been a number of trials that have done this. The vast majority have been in unselected stroke patients, which, if you think about it, might not be the right group to study, because you might want to study people at particular risk of SAP. And in fact, only one of these trials, which was Stroke-INF, selected patients who were only dysphagic patients for this trial. The bottom line is there have been a number of analyses done different ways to try and squeeze a positive result out of all of these trials, but the bottom line is that meta-analyses have shown that there is no benefit overall of preventative or prophylactic antibiotics given systemically. So to summarize this, preventative antibiotics do prevent any infection from happening in the group that received them. And this is largely driven by preventing urinary tract infections, which is in itself interesting, but perhaps in the bigger picture side of things, not such an important thing to want to do. Urinary tract infections consume far less antibiotics. They're no more or less difficult to diagnose accurately, but they aren't really associated with worse outcomes in the way that SAP is. So these antibiotics can produce any infection, but unfortunately they do not prevent SAP, which is really what they were designed to do. And not only that, because they don't prevent SAP, and people in the antibiotic group then also, many of them develop pneumonia, these trials actually ended up with people in the preventative antibiotic arms having more antibiotics than they would have done otherwise, which is important. And the most important thing from a health economic perspective really is that there is no real cost effectiveness of preventative antibiotics in patients with stroke who are unselected. So there's no cost effective reason to give antibiotics to everybody that comes through the door. Whether there'll be a future for any further preventative antibiotic studies is uncertain, but to me, in my mind, it looks very unlikely. Next slide, please. So moving now on to swallowing, which will be an area very close to the hearts of many of the audience. So we do know that swallow assessments are important, but what we don't really have is a huge amount of data to actually back this up, either in trials or in contemporaneous stroke unit care. So this is just an illustration from a study that we did using, again, SNAP data, individual patient SNAP data, where we looked at SAP in SNAP as an outcome, and then we looked to see whether there was any importance of how quickly people got either a swallow assessment, a swallow screen, should I say, on the left, or a speech and language therapy assessment if they'd failed or didn't have their swallow screen because they were too unwell. So the slide on the left shows the prevalence of pneumonia on the y-axis, and then the time from admission to swallow screen. And the graph on the right likewise shows prevalence of pneumonia on the y-axis and time from admission to speech and language therapy. So you can see that for the time to swallow screen, there is a marginal relationship with prevalence of SAP, which means that the longer the time to do the screen, the more likely people were to actually have pneumonia. But in the case of speech and language therapy assessment, this is a far more strong association, and in fact there's a very steep association within the first 24 hours. And the difference between a very quick speech and language therapy assessment within the first 2 or 3 hours and an assessment at 24 hours is associated with almost a doubled prevalence of SAP. So this implies that the longer you leave a speech and language therapy assessment, the more likely the person is to have pneumonia. What's very important to point out here that this does not imply any causality at all. And in fact, what this might simply represent is that the patients that had the more delayed speech and language therapy assessment had it delayed because they were already too unwell or too sick, or their strokes were too severe. And in fact, they were already developing pneumonia or already had pneumonia at the time that the assessment was done. We think that these findings are important because it does beg the question as to whether doing these assessments quicker could actually prevent SAP in at least some individuals. The difficulty there is that we know so little about what it actually is, the wonderful things that speech and language therapists do. We know so very little about what it is that they do that might be important here in preventing SAP. So is it invasive assessments? Is it modified diets? What is it exactly about the speech and language therapy assessment that might prevent pneumonia? Clearly, if somebody has a swallow screen that they fail, they'll be put in the mouth, which is a fairly blunt way of trying to prevent SAP, but it won't necessarily prevent SAP because people could still be aspirating the contents of their oral cavity or inhaling bugs from the nasopharynx anyway. Next slide, please. So people have looked at swallowing therapies in a little bit more detail, and Philip Bath's group did a meta-analysis and Cochrane review about swallowing therapies recently to see whether there was any impact on outcomes. And most of the trials that you can see here that were included about behavioural interventions are fairly old actually, and there have been no real additional studies from before, sort of since about 2006 really. So these are old studies, and unfortunately the methodological quality is not brilliant in these studies. They were often small, there was a lot of bias and a lot of issues with the actual studies themselves. But this is a forest plot showing the effect of behavioural interventions for swallowing therapies on the likelihood of developing pneumonia. And actually, in stroke patients, with a range of very heterogeneous behavioural interventions, which ranged from nurse-led swallow with oral stimulation, thermal tactile stimulation, with exercises or swallow therapies, and things that many of the audience will know a lot more about than I do. Overall, these do seem to provide a signal of some potential effect on reducing pneumonia, which is very interesting. So whether there's a future for doing more further sort of larger scale studies on swallowing behavioural interventions for discussion. Next slide, please. So metaclopramide or Maxilon is a drug that we use commonly in the hospital for treatment of people who are vomiting, and it works on D2 or dopamine receptors by blocking them, and in doing that it has what's called a prokinetic and antiemetic effect, so it stops people being sick and it propels food through the upper GI tract more quickly, which means it doesn't hang around in the upper GI tract to be regurgitated or aspirated. So there was a small phase 2 study which was randomized between metaclopramide for 21 days or placebo, and this was in patients with very severe stroke, so NIH average was 19. They were all NG tube fed, so clearly significantly dysphagic. And interestingly, despite this being a small study, there was a very profound reduction in development of pneumonia, and you can see here in the control group there was a very high prevalence of pneumonia, as you would expect in this sort of a group, and there was quite an impressive reduction in pneumonia. So it didn't get rid of pneumonia altogether, of course, but there was a very significant reduction. So metaclopramide is certainly in the offing as a potential treatment, or should I say potential means of preventing SAP for further evaluation. So there are some other medications that have been looked at with quite weak evidence, to be honest. So cilostazol is a phosphodiesterase type 3 inhibitor, which has multiple effects, and to cut a long story short, it has an effect on substance P, so it induces upregulation of substance P, which is cough mechanism. Here is that giving patients with stroke cilostazol could somehow stimulate cough and help to prevent pneumonia. So there have been a number of, I have to say, not very high quality studies, largely done in a particular region of the world, certainly not in Europe or the States, which seem to suggest in patients with chronic stroke that cilostazol could prevent pneumonia. Now, cilostazol in this part of the world that I'm talking about, certainly not in the Western Hemisphere, is used as an antiplatelet agent. That's actually what it's used for in secondary prevention, but we don't tend to use it in the UK. There have been no studies in acute stroke, so we have no idea whether this could be a preventative agent in acute stroke patients. If someone was to do a trial, there would be additional antiplatelet considerations to take into account, which would raise questions about safety, particularly in acute stroke. So there is ongoing uncertainty about cilostazol. Next slide, please. Next slide, please. Thanks. So what about impaired cough and lung function? And this is really the Cinderella area of pathophysiology of pneumonia, certainly when you compare to the amount of research that's been done on oropharyngeal mechanisms of aspiration. And there's very little known about impaired cough and lung function, but several parameters are affected after stroke. So there is complex impairment of voluntary and reflex cough. There is involvement of respiratory muscle weakness on the contralateral side to the stroke lesion. So there is expansion asymmetry between the right and left hemithorax, and there's hyperventilation of the actual affected side. And as I said in my earlier talk, these mechanisms contribute using afferent pathways to the brain to make patients potentially relatively tachypneic. So is this an area that could be exploited to try and prevent pneumonia from happening? Well, possibly. There have been some research studies done in patients with chronic stroke, which have shown that there's not really any major effect of respiratory muscle training. There have been quite a number of studies looking at cough reflex testing in acute stroke, and the bottom line there is that the role of reflex cough testing is uncertain in terms of what the benefits might be, and there certainly isn't any evidence that it will help us to try and prevent pneumonia. So again, these are areas that are sort of ripe for further research and have certainly got potential. Next slide, please. So on the subject of cough, another medication called ACE inhibitors, or angiotensin converting enzyme inhibitors. These again have an action on substance P to potentiate cough. So they actually potentiate substance P by avoiding it being broken down by angiotensin converting enzyme. And again, there's been a lot of interest over the years about whether ACE inhibitors can prevent pneumonia. There have been studies done in chronic stroke again, where ACE inhibitors may be used in secondary prevention for blood pressure reduction. In the acute side of things, there have been some acute stroke trials that have involved ACE inhibitors, predominantly looking at blood pressure lowering, but nobody's really ever looked at ACE inhibitors in acute stroke in terms of preventing pneumonia. Again, similar to cilostazole, an additional consideration in those sorts of studies in this case would be blood pressure lowering effects, which would mean they would need to be very carefully designed and there would be some safety issues. So again, currently the role for ACE inhibitors in preventing SAP in the acute side of stroke is certainly unclear. Next slide, please. So what about the environment? We obviously all work very hard to try and get patients with stroke rapidly assessed and onto the HAZU or acute stroke unit as quickly as we can, so into an appropriate care environment. And all of the data that has been gathered from randomised trials of stroke unit care, the stroke unit trialist collaboration, have actually demonstrated that one of the benefits of stroke unit care is that compared to not having stroke unit care, which is now obviously a relatively old-fashioned concept of being on a general ward, stroke unit care does actually have an effect on reducing the rates of pneumonia. So the good news is that there's something that we do on stroke units that does actually prevent pneumonia compared to being on an environment that isn't a specialised stroke unit. So what we know far less about, as I've already alluded to, is what those things are that we do. So again, this black box of stroke unit care. So as I've already alluded to, it's invariable that bedside swallow assessment and speech and language therapy assessments have some role in doing this. It may be that now in modern stroke unit care, with the volume of thrombolysis and thrombectomy increasing, certainly in some units, it might be that getting patients better from their stroke very quickly has an impact on pneumonia prevention. But we really still know very little about what actually happens on stroke units that can prevent pneumonia, and there's still a large amount of work to be done here. Next slide, please. So again, more for the therapists. I think Jenny may mention this a little bit more. There was a testing trial called TURN-MOB, and this was in 220 odd patients within 48 hours of stroke onset. And this was an intervention that consisted of modifying the patient regularly from supine to left and right lateral recumbent. And this was done every single 2 hours, in addition to passive mobilizations of all four limbs through the entire range of movement. And this intervention was partly done by the care team and partly involved any loved ones and relatives that had come to visit the patient. And you can already see that this is rather an intensive intervention, but the good news was that it did actually reduce the development of pneumonia by more than half. which is interesting. But again, this study was published 10 years ago, and as far as I'm aware, or as far as I can see, there's been no subsequent phase 3 evaluation. There's been no implementation study. So at present, the role of this intervention in clinical practice is unclear, and I'm sure many of you would have views about this as practicing therapists or nursing staff. Next slide, please. So positioning in bed, to me, this seems like a bit of a no-brainer. And it was interesting for those of you that were involved or heard about the HeadPost trial. So HeadPost was a trial where there was a randomization of patients between lying flat or sitting up to at least 30 degrees. To be honest, this was based on some rather wishy-washy data that laying people flat with a middle cerebral artery occlusion increases cerebral blood flow, but that doesn't necessarily apply to every stroke patient that comes through the door. The obvious problem with laying everybody flat is that, of course, in those who are aspirating, that could be an absolute red flag to develop pneumonia. So in the HeadPost trial, the idea was to randomize to one of these two positions. Unfortunately, as was always going to be the case, this ended up being a trial of very minor strokes because they were easy to recruit into the trial. So the question primarily wasn't really addressed in patients perhaps with more severe stroke as to whether lying them flat would help. So again, the knock-on effect there was that when they looked at pneumonia in this trial, they found no real difference in pneumonia, but they found what was really expected to be a very low incidence of pneumonia. So only 3% of patients in this very mild stroke group actually got pneumonia. So unfortunately, HeadPost does not tell us, despite being a massive trial, whether laying people flat or sitting them up is beneficial from the point of view of developing pneumonia. In my view, my humble opinion, in terms of venturing into territory that isn't really mine, for me, laying patients flat with stroke within the first few days, whether at risk of pneumonia and they're aspirating, to me seemed crazy, and I can't think of any justification for doing that. But there you go. Whether there will be any further follow-up on this with additional trials is unclear. Next slide, please. So what about if we look at combined care processes, and this has been done in several registries. We're currently doing this again with individual SNAP patient data. So there was one study done, I think somewhere in in Norway, where they looked at individual and combined care processes, a whole range of care processes, including things like early aspirin, early mobilization, getting a CT scan done. So some things that you might expect logically might not really be terribly related to developing pneumonia, for example, getting aspirin early rather than late, but certainly early mobilization could be of interest. And in this registry, so it wasn't a randomized trial, early mobilization as compared to late mobilization was associated with a reduction in pneumonia. And in fact, if more than 50% of the care processes were achieved, there was also a reduction in pneumonia as well. And this is shown in the small forest plot at the bottom of the slide. So what this means is unclear. My understanding of the AVERT trial, for example, was that nobody looked at pneumonia as far as I'm aware, so I don't think we have the answer from any randomized trials. Again, to me, it would seem logical that mobilizing patients early after stroke might seem a rational approach to preventing pneumonia, but we don't have the data, and at present, I think we don't have the definitive answer. Next slide, please. So very briefly on immune suppression, there isn't really much to say. As I alluded to earlier, immunologically, patients are at risk of developing infection, which includes SAP after a stroke. So an approach from a sort of basic science perspective would be to ask the question, could we use medications that could interfere with this immune suppression to try and boost immune responses and therefore reduce the likelihood of getting pneumonia? So this has been looked at quite extensively in experimental stroke and preclinical stroke, and there's a lot of data there, but the mechanisms involved here are highly complex. They're not fully understood, and really we're a long way from having drugs in clinical trials that could provide even proof of concept about reversing immune suppression. So we're a long way, unfortunately, in this regard, and there are currently no clinical trials that are looking at this, to my knowledge. Next slide, please. So in summary, trying to prevent stroke-associated pneumonia is incredibly challenging. We have very limited evidence-based strategies at the moment. There's a lot of common sense strategies, but we don't know the answers. Stroke unit care is clearly important compared to not having stroke unit care, which we would expect. There is evidence for that, but we still need to try and untangle what the processes of care are on the stroke unit that are actually beneficial. We also need to look for additional care processes. We also need to look for novel therapies in terms of medical treatment. It's important, in my view, that dysphagia and its management is very important. Mobilization could be important, but needs further evaluation. And medical approaches are currently very lacking, and we need a lot more clinical trials and research. Next slide, please. Thank you very much.
Hi everybody, my name's Jenny Harrison. I'm one of the stroke therapy team leads at Salford Royal. I was really pleased to be asked by Amit and Craig to talk today to discuss the role of physiotherapy within stroke-associated pneumonia. Although a medical model really drives a large portion of the care, I think it's important in the treatment of pneumonia to understand the varying roles within the MDT and how we can support the patient's journey. I will say this is my first time presenting on MS Teams where you can't see your audience, so please forgive me and hopefully we can get through it. There should be learning for all, whether you're in the audience as a doctor, a nurse or an AHP like myself. So I think as a stroke physiotherapist, I might be talking for myself here when I say that we focus lots of our education and studies on neurology and might not always be thinking about our respiratory management. I think sometimes if you work in the rehab setting, you might often not be exposed to the acutely poorly patient, and it might be in your area that the patients get escalated or maybe not to higher level care. We certainly have at Salford seen an increase in our number of stroke-associated pneumonia since centralisation, I feel, and becoming the comprehensive centre. Obviously with that we've had the increase in numbers, and maybe obviously we're keeping patients until they're medically fit for repatriation. So I'm going to talk today about prevention. I think some of the things that Craig's mentioned, I don't think as a physiotherapist we could talk without mentioning positioning and mobilisation. We'll look at the indications for chest physiotherapy, and I'll try to see my options as a respiratory physio as a bit of a toolkit, thinking about what's in that toolkit and trying to select the appropriate item which is given the clinical presentation. So I think as well, lots of the therapists will know that sometimes the evidence in some of the things that we do can be low and not that robust. So it's a good opportunity to have a look at the evidence that's out there. So our involvement really comes from looking at cough and secretion clearance. So you know, the mucociliary escalator and cough reflex maintain optimal function for the respiratory system by removing secretions and preventing airway obstruction. For a cough to be effective, there must be sufficient airflow to detach the sputum from the epithelium and mobilise secretions so they can be expectorated. When peak expiratory flow falls below 160, it indicates an ineffective cough and the airway secretion becomes inefficient. But we do find that patients that have a peak expiratory flow of less than 270 will still be inefficient when they become poorly because of a pneumonia. So when we combine respiratory muscle loss with strength, an ineffective cough, decreased ventilation, this can lead to the high risk of developing pneumonia, atelectasis or respiratory insufficiencies. For a cough to be effective, you need to be able to take this deep, sufficient breath. The glottis needs to be able to close, which allows increase in interthoracic pressure, followed by an expulsive glottic opening with the abdominal contraction, which produces the air to be forcefully expelled. This cough expiratory flow can be measured and is known as peak cough flow. It is mentioned quite a little bit throughout the studies because they use that as a form of measurement. So, going to start with prevention. I think if we're going to talk about how we support the management, we probably need to try and look at prevention first. And I think as we go through this, with all of the research, we need to evaluate it to determine if it has any impact for us in terms of clinical practice. So just mentioning peak cough flow there, this study by Katie Ward was looking at functional residual capacities, and it was looking at two different positions. They were looking at the semi-recumbent position and the upright position, and looking at the difference between functional residual capacity. They did find that the difference between the two positions in functional residual capacity was 210 litres. If we said there was an attribute to the fact that functional residual capacity has an impact on peak cough flow, indicating that obviously when someone is in a lying down position, they're less efficient than the upright position. The graph to the right hand side there shows the difference between a patient who has mild right hemiparesis and a healthy control in terms of their functional residual capacities. I think just little things really. What we tried, thinking about making sure that people are really upright. So we tried at lunch times joining in with the nursing staff on the ward to make sure that patients are sat as upright as possible to have their meals. Just thinking about the cohort of patients that you might have on the stroke unit. Often sometimes the more poorly ones that might be on the modified diets might be sometimes in bed in the early stages, so getting them in that really good upright position so that if there is any problems and they do need to utilise their cough, they've got the best functional residual capacity to do so. Some of this we've just looked at with Craig. It is important to draw on and have a look. So as Craig said, Turn Mob had 223 patients, so they split that in half. Half of them had the methods that Craig said. So they had the passive range movement. They were turned every 2 hours into different positions. And out of those, I think it was 111 patients that were in that cohort, only 14 of them developed a pneumonia, in comparison to 30 in the control group, which obviously does show a large difference. However, HeadPost is a huge trial, and that trial showed by leaving someone flat for a 24-hour period, it didn't have any negative effect on pneumonia. However, we do need to mention that the patients that were excluded were the high-risk patients, and the patients did have a relatively low NIHSS. So for therapists, I don't think, as Craig said, it doesn't sit right with us to maybe leave some of our patients exposed to that lying flat position for an extended period of time. And I think it is really important to work with the nursing staff on the ward and work with the healthcare assistants on how we manage and support positioning. You know, the 24 hours in a day, it's a really long time frame. I think we all need to take responsibility for making sure that patients are, you know, changing positions. Obviously on the ward, they do have a turning programme anyway. But I think we all need to take accountability for managing positions when a patient is in bed. Just to draw on the RCP there, it's quite non-committal, to be honest. So it says when lying or sitting, patients with acute stroke should be positioned to minimise risk of aspiration and other respiratory complications. And that's probably drawn on the fact that the evidence is inconclusive there and there is further work to be done. Mobilisation. What I've done here is I've just drawn on some work elsewhere. There isn't lots of information specific to stroke, if we remove advert for a second, on mobilisation in relation to aspiration pneumonia, but I think it is quite topical at the moment in other areas outside of stroke. So the trends in the data are in favour of early mobilisation. I think if we look at the fact that ambulation facilitates secretions mobilising themselves and improves the pulmonary toilet, preventing pooling of secretions. So I think it makes sense that mobilisation helps, but we need the evidence to support. Some of you will have heard of the ERAS pathway, which is a designed to support early mobilisation after surgery, and that there are other trials within elderly medicine, both looking at hospital-acquired pneumonias and community-acquired pneumonias. I think it should be thought-provoking to determine if some of these studies should be carried out in the stroke population to support mobilisation as a method to reduce incidence of pneumonia. I don't think, as Craig said, we can mention mobilisation without a discussion over AVERT, and we probably need to draw somewhere in the middle. AVERT, it was most detrimental in very early mobilisation and at a high intensity, probably more of a higher intensity than what we can deliver on stroke units. We have to look at RCP and more recently the NICE guidelines, and then decide from there where we feel comfortable. I think it will be sensible to remember what AVERT advised, and I think that we should be able to provide a service that at the moment supports both. You know, the short frequent sessions that AVERT alluded to is the service that we try to provide at Salford. So hopefully we can mobilise these patients without going against some of the advice documented in the AVERT trial. I think we probably need to be clear across the board of the MDT when chest physiotherapy is going to be indicated. I think we all need to recognise that it's because when we ask for chest physiotherapy, we are looking for a reversible cause. So as a physio student, you'll all remember Alexandra Howe's book was our Bible for chest physio. And she states 3 variables that you're looking for. You're looking for retained secretions, loss of volume, or increased work of breathing. So they are all things that potentially we can support and help to look for a reversible cause. So we need to be communicating with our doctors, looking at the chest x-rays. So we can see here, you know, we're looking for a volume loss, that lobular collapse, or obviously the white out there. Have a look at your blood gases, and again, just keep thinking to yourself, what is the clinical indication that you can make a change here? If we're thinking that this is going to be more of a micro aspirate and the chemical process of pneumonia is set, it might be that we can't make too much of a difference, and it'll be potentially unlikely to reverse the symptoms. I think sometimes we find it difficult. Some of our patients have their ceiling of care set at a ward level and wouldn't be for escalation for NIV. And at times we do find that medical management is optimised, and it might be that, you know, seeing if chest physio can help in any way is what sometimes we're challenged and faced with. So if we do feel we can support the acutely unwell patient, we need to clinically reason our intervention. And to do that, we need to synthesise the evidence and see where that lies. So here is a diagram which shows some, it's not an extensive list, it's some of the chest physio techniques that we can utilise. I've used this one. I think it quite nicely breaks down some of the different techniques. So it looks at it in 2 arms. It looks at it in proximal techniques and peripheral techniques. So with the proximal airway clearance techniques, we're looking to augment the cough by assisting inspiration, expiration, or both. They're often described as cough augmentation techniques to support or imitate a cough, where the primary goal is to move the secretions from to the larger airways. The secretions are generally sitting more centrally versus the peripheral secretions. So these are your assisted inspiration, assisted expiration, a combination of the 2 together. We are going to look at some of them in a little bit more depth. We don't have time to look at them all. So we are going to look at breath stacked techniques and mechanical insufflation exsufflation, known as the cough assist. In terms of peripheral sputum clearance techniques, these are manual techniques with the aim to improve ventilation, loosen secretions and enhance mucus transportation from the peripheral airways to the central airways with higher expiratory than inspiratory airflow. So the first one is breath taking. And evidence behind this. Lots of the evidence is in neuromuscular conditions. So I think from early on we need to point out that there is research required into the specific stroke population. Craig has mentioned, hasn't he, how that stroke associated pneumonia potentially is different from the other pneumonias, and we would need to know how our treatments impact specifically within our population. With breath stacking, or it can be known as air stacking, slow inspiratory breaths are taken, stacking one on top of another, followed by a short hold and a slow expiration. The aimed at filling the lungs to a desired volume, increasing inspiratory pressures. So hopefully we get increased oxygenation and mobilization of secretions. The research suggests it can help increase peak cough flow and maximal inspiratory capacities. The research also suggests that joining breath stacking together with a manually assisted cough has been found to provide the greatest results and increase peak cough flow. For those that don't know what a manual assisted cough is, it's when a therapist applies pressure, which is firm, on the expiration phase to increase the cough, and that is at the top of the stomach. So I've drawn this information from an article which was written by Michelle Chatwin, and it was been described as a state of an art review. It sounds a little bit like Craig getting together with his colleagues, which are recognised experts in their fields, to document what they feel is appropriate for this population. After looking on Twitter, finding her on Twitter, I found out that she is a consultant physiotherapist. She's written 36 articles and had 1,600 citations, so I felt like I was happy to cite her work here today. This is the cough assist. This is known as, or known as MIE, so mechanical insufflation exsufflation. This is one of the devices we use here at Salford. So the aim of MIE is to deliver a deep inspiration to the lungs, followed by an immediate deep expiration. Applying sequentially positive and negative pressures swings via the full face mask. It can also be attached to a tracheostomy tube as well. The insufflation aims to fill the lungs and the exsufflation aims to empty the lungs of air. The rapid switch from positive to negative pressures aims to simulate airflow changes that occur during a normal cough, with the hope of moving secretions. I just wanted to show you this graph. It's quite a nice graph that looks at different ways to draw on your breath. So along the bottom there's tidal volume, so that's your volume during quiet breathing. You've got the grey, which is for the inspiration, and the white represents expiration. So moving along, you've got forced vital capacity, and then we've got peak cough flow, which is unassisted. You've got your breath stacking there, which is down as AS, so you can see as they've stacked the breath, so they've taken a small breath and then stacked more breaths on top till they've got to their maximum volume, and then there's the breath out. Glossopharyngeal breathing is on this graph, but I've not spoke about it today, primarily because it's not something we use in the stroke cohort. It's more for your spinal cord injuries. And then MIE, which is also known as the cough assist, we can see there where we take this slow, steady breath in, and then also the move down into negative pressure. And it just shows you nicely that it's the only one of the techniques that does go into the negative pressure on an outward breath. just going up to the next level, we can see your flows there. If you go back to your AS, which is your stacked breaths, you can see with each breath that has been taken here, you can see the spikes in volume. And then if we move along to the MIE, you can see that slow, steady flow. I wanted to look at the cough assist a little bit more. I think it's an adjunct that we use as a go-to, probably when we feel like we're not going to be able to make a difference with our standard techniques. I think as a physiotherapist as well, we probably know that there is a low level of evidence there, but it's not really robust. Again, the evidence is neuromuscular, so we need to decide where we draw our conclusions from that. Just before we look at the evidence though, in terms of the physiological effect, so we need to specify it with a general build-up. We say to use a higher expiratory volume than inspiratory pressure, and also with your patients that are potentially weak, that we do use the insufflation a few times before at the end before we finish, so we don't finish on a forced expiration. They do say it might prevent reintubation, which is a bit of a sweeping statement. And also there is quite a list of contraindications, but I don't think in stroke lots of them affect us really, not on a ward. There is quite a lot of research into bulbar inefficiencies. I think it is worthwhile mentioning it. There is evidence to say that sometimes with a bulbar insufficiency, we can cause laryngeal adduction when the forced breath is taken in or out. I believe there is studies to show, though, in this population, if we ask the patient to take an active breath in themselves first prior to the use of the machine, then this causes laryngeal abduction and for the airways to remain open rather than closed. So the evidence, I think like most, we find for and against. Again, going back to Michelle's Chatwin's study, which is where I pulled some of the positives from, we do see a stability in oxygen levels, we do peak inspiratory pressures, mean airway pressure and increased work of breathing is improved after sessions. And also there is literature out there that says that this is less invasive than suction. You know, suction sometimes is our go-to, but actually there is a trauma association there, and that patients do find the cough assist more comfortable, although sometimes it can be tiring. The evidence, even though we're going to have a look at some of the evidence and that is low level, most European and American guidelines do still recommend the use of a cough assist. So 2 systematic reviews, which are in the last few years, have looked at the evidence, and really the conclusions aren't that great. So trying to look at the studies, they all look relatively small. They're all unblinded, but I think we might need to recognise that, you know, we are using a device and it probably is quite difficult to blind that. The methodological quality seems to be quite poor. Lots of the focus is on peak expiratory flow, and it probably can't be used in isolation, because although it says that we improve cough efficacy, it doesn't necessarily always attribute to removal of secretions. It doesn't show long-term effects and also impact on mortality, morbidity and quality of life for the patients. Because when I looked at this, it concluded low level evidence, I did want to look at why the methodological quality was so poor. So I have pulled on a few randomized control trials just to try and synthesize that a little bit more. And to understand really that, you know, we do use this device, and obviously it doesn't run, you know, with practice. I think it might be because when we get to this stage, it might be that we are limited in other options. So we take that low level evidence and we use it because there might be a potential to support. I think you can see by looking at the populations in all these studies that the sample sizes are really low. They all interventions looked at the effects of MIE with a manual assisted cough, so in isolation or together, to see if we draw on a stronger cough when the two are joined together. One study also looked at use of intermittent positive pressure breathing versus using the cough assist. So even though that they are all small, most of them did have good results, increasing peak cough flow. So we can see small changes in volumes within some of the studies. Three of the four studies here unfortunately use peak cough flow as a primary outcome measure, so we've just discussed why that might be difficult. A study, a randomised control trial that Michelle Chatwin did do, looked at drawing from other conclusions which probably run more parallels with clinical practice. So she found that there was a shorter treatment time, that they used the VAS to quantify improved auscultation and removal of secretions, although that is subjective information and could cause potential bias. So when we draw comparisons with this kind of research to some of the research that Craig and Amit have shown, I think we're certainly down on numbers and quality. However, all that said, our guidelines, so the British Thoracic Society do recommend considering MIE as a treatment option for patients with bulbar muscle involvement who are unable to do breath air saccing, or for any patient who remains unable to increase peak expiratory flow to effective levels with other strategies. And I think that comes, doesn't it, to looking back into that toolkit, what we've got, and it might be that we feel like we've explored and utilised what's in that toolkit, and it might be that we feel that by using the cough assist, there is potentially a difference it can make. They also recommend combining the cough assist with an assisted cough. So the literature does show that the two together produced the strongest and most effective cough. However, to do that, that would mean that we're treating a patient as two therapists together. And I think that that would be more of a luxury. You know, you're not often working with a patient that would have a hold of their own mask, unless other areas use a different device. Ours is a mask that the therapist holds on rather than something that is around the back of the head. The NICE guidelines, I think it is important to say this, that chest physiotherapy should not be done as routine in cases of pneumonia. I think that is common sense. I think that goes back to understanding and thinking about what it is and going back to that reversible cause. So there needs to be something that we can change, and it isn't the case for all pneumonias. There is a limited evidence, so this is from NICE, that treatment can slightly reduce the duration of hospital stay, and that positive pressure can slightly reduce fever and treatment and reduce the duration of antibiotic use. I don't think that we can talk as a physiotherapist about respiratory chest care without suction. I think that when we are faced with that acute deterioration, so that might be that we've got audible or visual secretions, the acute desaturation, you know, we've probably been there before when the nurse comes to us and say this patient's saturating at 70 to 80%. We can hear the secretions, what shall we do? It might be that the patient has got an inability to generate their cough themselves, as we've discussed, but we don't have the time necessarily to go through some of the treatment options that we've mentioned already, and this provides a quick solution to the problem. There are two options we have, isn't there? We've got nasopharyngeal and oropharyngeal. Personally, I tend to go nasopharyngeal. I think this is because our cohort of patients are generally awake or more alert than the use of a Goodell airway. All that said, we do sometimes have patients with a GCS of 15 but have no gag reflex, and then, you know, that would probably be the only time that I would maybe use oropharyngeal. I think that the two things to mention here is the sizing of the tubing. So we are looking for length rather than width. So, and it's important to look at the distance from the nares down to the epiglottis, and the airway should sit approximately 10 millimeters above that. If it is too short, it won't separate the soft palate from the pharynx, and if it's too long, it can pass into the larynx and aggravate cough and gag reflex potentially. So for females of average height, it tends to be a size 6 airway, and for males of average height, it tends to be a size 7, but it should be considered given that it can make a difference. And we might all be able to relate that to clinical practice of sometimes when we've had an MP airway not been as effective as we may have thought. It might be because actually we've got the wrong size airway in. I did look at patient position. We probably all have our own techniques. There is lots of different ones out there, and medics will probably be more familiar. There is the sniff technique, which is with the slight flexion with head extension. So I think we can create that by putting a towel underneath the top of the shoulders. We do need to think about contraindications and risk when it comes to suction. Basal skull fractures, I think we probably all know that one doesn't necessarily affect us usually within the stroke population, but certainly we do have patients that are anticoagulated and do have low platelets. Obviously, thrombectomies are on the rise. These patients will have potentially had thrombolysis, or you've got your patients, as we said, that are on the blood thinners. So we do need to look at platelets, and in the situation where someone might have low platelets, you need to speak to the doctors and the consultants about appropriateness of this intervention, as we do know that it can cause bleeding and trauma. And the last thing that you want to do is be on the phone to ENT asking to stop bleeding. Some of the other risks there is that the MP airway can migrate. Hopefully you are using ones that have got a pin or they've got a flange on the end, so that doesn't happen. There is a possibility of a vomit if you cause a patient to gag. Hopefully that doesn't happen if you're going nasopharyngeal. And this is a short-term thing, so if it is moving more long-term, you might start to see some ulceration. I'm just going to mention inspiratory muscle training. Craig did mention it a little bit then. The aim of inspiratory muscle training is to improve pulmonary function, increase respiratory muscle strength, improve exercise capacity, potentially reduce the incidence of pneumonia and improve quality of life. So they're quite big statements there. And when I looked at the evidence online after speaking to Craig about it, there is quite a lot of stroke specific evidence, and I do think after this certainly something that I might choose to look at a little bit further. Craig did say that there was a study by Pollock who in 2013 which didn't find any particular effect on incidence of pneumonia, but I have pulled on some other systematic reviews and I'm going to have a look at some of that evidence. But for those people who don't know what respiratory muscle training is, it is a device which is generally used with a nose clip. So we're looking at you know, inspiration, expiration without any use of the nose. It is like training any other muscle. So you're looking at a resistance. Generally, the research is about 30 to 60% of a patient's maximum respiratory pressures. And it's the same, again, as we would do with training other exercises. So a patient will use this device and they'll do 10 to 15 reps of it. Or they'll do, you know, 3 to 5 sets a few times a day and up to 5 times a week to see if they can train those muscles. I thought that these devices potentially were used more chronic, but again, there is some research more subacute that is interesting. So again, with most literature, you can find studies that are for and against. As we've mentioned Pollock in 2013 didn't find any change to incidence of pneumonia. The two systematic reviews that I've used here are in 2016 and 2020. Draw on a meta-analysis, the first one in 2020, and look at maximum inspiratory pressures of using the device. All of them show a relative change in maximum inspiratory pressure strength and a potential decrease in risk of complications, showing a potential significant improvement in the strength of these muscles, and potentially offer additional therapeutic tool aimed to reduce the respiratory complications. I've just drawn attention there to a randomized at the bottom, and that was done in 2015 in subacute patients, so patients within 2 weeks of onset of the stroke, with 109 patients, similar to what I mentioned before. So 5 sets with 10 reps twice a day, and they did that for 5 weeks for up to 5 times a week up to 3 weeks, finding an increase in both maximal inspiratory pressures and expiratory pressures. So I think, like Craig said, there is lots of more work to do, but there is certainly emerging evidence out there within specific to the stroke population about respiratory muscle training. There is lots of evidence out there that we need to look for studies that obviously are of a good sample, well designed and high quality to then draw our conclusions. But I think it does give us options to explore in the future, which can potentially have an effect. In summary then, so we need to think about what it is that we're trying to achieve, and that we might have a important role in if a patient has aspirated a large volume of feed or vomit, or there is a high secretion load, a lesser role with microaspirate secondary to dysphagia, where which is a slow insipid process. The evidence base regarding prevention has a focus on positioning and mobility for physiotherapists, but requires further research. I haven't had an opportunity to talk too much about the MDT approach, but it is so important that if we think about a patient's day and having 24 hours in a day, for some of these patients, they are in bed, and we've got to think about how as a team we can work together, you know, as the therapist, to make sure that positioning, mobilization and secretion clearance are optimized. I think it's important that if a therapist has used a nasopharyngeal airway to remove secretions, they've obviously felt like it is required for an extended period to have sited that airway. So it's having the continued support throughout that day for removal of secretions, and I think the only way we can do that is together. There isn't any evidence to support routine prophylactic chest physiotherapy for pneumonia, and the evidence highlights the need for ongoing clinical research to test assumptions and to define a standard set of MDT goals for airway clearance. And yeah, so just a finishing note, the key to success is the 24-hour management approach. I think that's it. Thank you.
Obviously, while people are thinking of any questions, or obviously what to type any questions in the box, I thought I'd start the ball rolling, if that's okay, and just fire a question at Craig and Amit, really, just to say that really interesting data regarding the swallow assessment data and the dysphagia. And I just wonder, Craig, has there ever been any studies to look at an association or correlation with the amount of time it takes a patient to get in from onset actually to the hyperacute service? Obviously using a paramedic hat and the amount of times that we went out to possibly elderly patients who have been on the floor for quite some time alone before they've been able to actually alert somebody and then have an ambulance actually get to them and bring them to hospital. I just wondered if that had ever been looked at, and then any correlation between the swallow assessment off the back of it?
Yeah, that's a good question. I can't remember in the SNAP study that we did with Ben Bray whether we adjusted the analysis for the duration from sort of onset to arrival at hospital. I can't remember whether we did that, but we are doing that in the current analysis at the moment with Marco. And I think you've touched on a really important point, that if we're saying that, so we're saying that in some people they have pneumonia before their stroke, so we can't really prevent that after the stroke, but there's also a group of individuals where there's a whole load of other things going on before they actually arrive at the hospital and get to the unit and to the team. So clearly the amount of time somebody's been down, as it were, the downtime and the transfer time is going to be really very important. And again, I didn't really labour the point, but there's a group of individuals that come in with even not terribly delayed sort of transfer from onset, maybe just a few hours, and these people will already have aspirated at scene, particularly if they've been found down and in a sort of unfavourable position. So I think there's, I'm not sure how easy it is to unpick from SNAP the pre-hospital times in terms of transfers and that aspects of things. And I know this is something that we're currently having a slightly interrupted discussion about offline, but Marco's currently looking at, he's stratifying the time from onset to arrival at hospital. For me, if you want to prevent SAP, you've got to not only get people to hospital quickly after the stroke onset in terms of, you know, the ambulance side of things and get them sorted out quickly, but you've also got to get them to, you know, from the onset of stroke to the ambulance has got to be quick as well. And I think that's a really important part of the chain, which is rarely considered.
Yeah, definitely. And I think that was more the point of the question in regards to the population that obviously we're dealing with within stroke. As I say, a lot of them are elderly. A lot of them, you know, maybe possibly live alone and can't actually get to a phone to alert somebody. And like you say, it may then link in with Jenny's talk and positioning as well, in that the patients quite often we find them on the floor and have been down for, you know, for some time. So yeah, I think it's really interesting and possibly something in the future to look into.
We do have further webinars planned. I've posted in the chat function around that, and they're on our website. And this event has been accredited, I think 2 or 3 credits from RCP, CPD for the doctors amongst you. So on behalf of the network, I would like to say thank you to our speakers, Craig, Amit and Jenny from Salford Royal Stroke Service, and look forward to seeing you at future events. Thank you very much.